But what I started with is some discussion of the, I guess my slides are not there. I turned them in this morning around 10 or 11. But anyway, the thing that I think bothers clinicians is, I mean, do people really die from this, number one? And how did they figure out that some bacteria on a scope really is what infected? My first reaction when I read the newspaper article was, this is a bunch of microbiologists junk, and that somebody found a bacteria on the tip of a scope, found it in a patient, and we see these bacteria in patients anyway, and they're all sick patients, so now they're going to have a big hullabaloo about scopes causing this, when really it's just an endogenous bacteria that the patient's sick, and he's got CRE. Anyway, that was my reaction. Over time, since I am an endoscopist, I had to read about this and learn about it a little bit. I did come to believe that the way it works out, and the first few slides talk about this, that there was an infection, and they took bacteriologic samples, and it became suspected at this hospital, and they took samples from the tip of the scope and from the bacteria from the patient, and they were able to identify that it was the exact same strain, exact same bacteria. Then they called back all the patients who had had scopes with this scope, and when they matched scope for patients, there were 100 and, I got it on my slide, 160 patients who, and 46% of those patients had that exact identical bacteriologic strain. They felt there was no way that could happen without transmission. There's enough of a fingerprint on these bacteria. So once that happened, then the light was out of the, the cat was out of the bag. Other hospitals began looking, and then you had Cedars-Sinai. The first one was in the east, and Cedars-Sinai, and then UCLA. And the number of infections was several hundred. The number of deaths were 12 to 13. I still, as a clinician, always am suspect of things. I'm myself don't feel 100% sure that all 12 of those people. I have it on a disc in my pocket here. If you want to just take my thumb drive. The slides are not exciting, but they're probably more easy to follow. I have it right here on the thumb drive if you want it. Yeah. I did turn it in. The lady downloaded it, uploaded it, requesting Vitale. But I think there's no question now that there have been deaths, there are infections. The best thing I found out in preparing for this talk is the first thing that you find when you click scope infections online are the lawyers. So if you don't think this is important and you don't believe in it, believe me, the lawyers believe in it. Let me go quick through these first slides. So 142 cases in 2010, 13 people died. These bacteria are invasive. I'll just move quick because we lost some time here. Now, this was interesting. I went through all the data back to 1990, and other bacteria have been identified as being the cause of scope infections over the years, including hepatitis, and now HIV at Duke, Mycobacterium from bronchoscopy. So this is not new. However, the difference is, whenever there were failures that caused these, and this probably is one of my best slides because it tells you it's from a paper in 2015. What are the causes of this? Well, failures and mistakes in the reprocessing, thing, inadequate systems, basically inappropriate brushes, basically if they're damaged or improperly maintained, contaminated environment, surfaces, insufficient hand hygiene, and overuse of antibiotics. So those are things that can lead to it. And the scopes have all these little holes on the end that you've got to worry about, and then you've got the issue of the elevator for the ERCP scope and the EUS scope. the newest design was more of a problem. So the first cluster of patients, was in 2013. As I said, they obtained cultures after manual cleaning, and this bacteria was recovered from the terminal section of the device and were highly related to the outbreak strain by electrophoresis evaluation. And there were 91 with culture positive who were notified. Of the 50 returned, 46% positive. Then Virginia Mason, 11 died. Then you got Ronald Reagan Medical Center. You got Cedars-Sinai. And a particular infection specialist pointed out in one article, this bacterium's resistance was the perfect storm because it just survived whatever you did to it. So then I put a few slides in here. So now I'm a clinician. I'm not a microbiologist or a scientist. But what do we tell our patients? How do we deal with this? First of all, you do need to be proactive about it. I think a lack of communication could put you in a little hot water because you want to give them options and let them buy into the fact that they're happy with the ERCP options. We want to tell them, first of all, as a doctor, not as a medical legal defense expert for yourself, you want to tell them what symptoms to look out for. Explain the benefits of your procedure and their need for procedure. Why are you doing this? I mean, why is it really necessary? Give a reasonable explanation of the risks of the ERCP, including infection, and discuss the risks of alternative procedure. The biggest thing I see as an expert witness for lawyers is, in the defense of my doctors, is that they really never discussed alternatives. So if someone gets a really bad problem, they say, gosh, if I had ever known that I could have had a PTC, I would have chosen that. Which is not true, not right. But I'm just saying, you discuss alternative procedures, which explain what's being done to the scopes to minimize the risk, and then discuss the things that they can do to protect themselves. So none of the newly reported resistant infections were related to EGD and colonoscopy. That's very important. I did point out that we have Pseudomonas, hepatitis B, all those other things on those older studies. However, what's important on those older studies is when they fixed the problem, in the processing, the problem went away completely. And it was easy to fix because they didn't have some of the problems we have with the current scopes. So none of these newly resistant infections are related to EGD and colon. So you can tell them that. All right, here are the mild symptoms. Sore throat, which of course every patient has after an endoscopy. Mild abdominal discomfort. I think fever or chills, that may be something you may want to tell them to come back in for. And if you get called at home at night, I think, and you did an ERCP, I think you probably should bring these people in more than we used to and put them on some antibiotics and watch. Other symptoms may be more simple: chest pain, severe abdominal pain, trouble swallowing, breathing, nausea, vomiting, black or tarry stools. Basically, they're the kind of things that anybody could have. But I do think you need to give them a list. I think fever is pretty important, and chills on the list for a bacterial infection. So explain the benefits. The important is you have to tell them it's important to your health to have these endoscopic procedures. Just because you read this in some internet site, you don't have to be worried about it. You need to go ahead with it. An important point is to point out to them is just because these are terribly resistant bacteria, they're actually not resistant. They're resistant to antibiotics. That's what's bad about them. They're not resistant to the disinfectants. You just have to get the disinfectant in contact with it. And that depends on the team that you've got. That's why I love the discussion that several of you mentioned, the team approach and making sure all team members really understand what they're doing. Because you've got 10 different people washing scopes, and it's often passed down to the least educated person on the team in some hospitals. So you got to get, because the instrument's reusable, we can't gas them all. You can't open this sealed container. There's a sealed distal hood. It's part of the ERCP scope, and it could conceivably retain some stuff. But to open it destroys the scope, so it's not realistic. So the elevator channel can be manually reprocessed, and I'll show you that. Use brush and magnification on every single cleaning. And then you can use chemical testing or quarantine too, although I'll show you some data at the end that's been shown that's not cost effective or really necessary. But basically, we all know that manual cleaning and high-level disinfection, everything, it's possible you can still transmit these things. So you have to tell your patients that is certainly possible. However, we've already seen pictures of the elevator. Forget that. There's the brush. There's the little magnifier glass that we use. This is a little video. If I can make it start, let's see. what do I push to make my video start? If I push forward, will it go, or do I push the next slide? No, let's go to the back slide. Can you start that video? There it goes. It just shows you push one brush in from the top, then you bring another little brush from the bottom, you clean it out, you open the elevator. I'm just going to move forward. We don't need to see more of that, but you open the elevator, you push it up, and then you go. You clean everything that you can with a magnifying glass. Now, here's the important point, that since the advent, Virginia Mason was hit as one of the hardest hospitals in Seattle with this. And since they went to the manual reprocessing and their new infection control plan, which they included scope quarantine and bacteriologic testing, they had no further cases of transmission. They were looking. Now, this is this study, and I'm getting near the end here. This is the study that talked about the cost of all this versus the quality of life years gained. I mean, I'm, again, looking carefully at this article. There were 4 options. Just perform your ERCP, followed by the recommended cleaning processes, which are just what I showed you, the machine plus the brushes and all. But then the next one would be add in there an endoscopic culture and hold till that culture comes positive back or negative. Then you can do ethylene oxide, sterilization of the scope, full sterilization. And then number 4 is just stop doing ERCPs in your hospital and do a lap chole with common bile duct exploration. Or, you got a nice little dilated pancreatic duct, just do a Pusto and take out half the pancreas. I mean, those are real low-risk procedures as compared to ERCP. So, and basically, the outcomes they looked at was the incremental cost per what they called quality-adjusted life years. And there's the reference there. I thought this was interesting, but basically it cost you, I forget the number, I should have put it on the slide, but $40 million for one quality life here if you went to some of those bottom line ones. But basically it came out with an institution with low CRE prevalence, which is most of us. ERCP with the FDA recommended processing is the most cost effective for mitigating CRE transmission risk. Only in settings with extremely high CRE did ERCP with culture and hold become cost effective. That's what Seattle did, and they stopped the infection. So if you're having any problems or you're of concern, you do the culture and hold test. And then this was actually the website. I enlarged the type so you could read it better, but this is what came up precisely when I typed in scopes and infections. So when a patient's getting, any information, hey, did you hear about infected scopes? The first thing they're told is there's a lawyer ready to take your case. And I thought that's important for us just to be aware of. Obviously, we all do some defensive medicine. But in the end, I think be aware of who's cleaning your scopes. Make sure the least person on the team really knows what to do, because someone else may have just told, here, take this brush and clean it. You are responsible. It's not so much a captain of a ship thing, but if this ship goes down, you're certainly going to get blamed, not just the hospital. And then remember to talk to your patients about it. I think that's important if you do ERCP, even routine endoscopy, and put them at ease. Well, thank you very much.